Good morning from Miami Beach. This is Dr. John Bennett broadcasting for Neurosurgical TV.
Can you see my?
Yes, it's not presentation mode. Okay. Yeah, perfect.
Thanks, Dr. S.K. Mukherjee. Thanks, John Bennett. Can I start?
Yes, you can start.
Welcome to session 3 of Paediatric Neurosurgery webinar, organized by Neurosurgical TV and Department of Paediatric Neurosurgery. I must thank to John Bennett and Dr. Sudipto Kumar Mukherjee. I am Dr. D.M. Arman, work as an assistant professor in Department of Paediatric Neurosurgery, going to present my talk on complications of BP shunt. This is our hospital, National Institute of Neurosciences, situated at Dhaka, capital of Bangladesh. This is 500-bed hospital. We, more than 40 neurosurgeons work here, near 3,000 operations done in last year. In the Department of Paediatric Neurosurgery, we did 538 neurosurgeries in 2022. From 2013 to till now, we did ventriculoperitoneal shunt 972. I did few studies regarding outcome, accuracy, and some complications. This is the article published in Bangladesh Journal of Neurosurgery and Journal of National Institute of Neurosciences, and few journal published by Dr. S.K. Mukherjee, hydrocephalus related with TOT infection and management of loculated hydrocephalus, published in different journals. And others study of outcome of BP shunt is in progress. Introduction. Ventriculoperitoneal shunt is one of the commonly performed neurosurgical procedure and most popular CSF diversion procedure worldwide for the treatment of hydrocephalus. Till now, the standard treatment of hydrocephalus is ventriculoperitoneal shunt. The technique of using the peritoneal cavity for CSF absorption in ventriculoperitoneal shunting was developed by Kaush in 1908. A wide range of complications can occur, such as shunt block, shunt infection, shunt migration, and various abdominal complications. The complications of ventriculoperitoneal shunt may lead to failure of the procedure, necessitating revision or reinsertion in most of the affected patients. BP shunt complications can be divided into 3 broad headings: mechanical failures are obstruction, fracture, disconnection, migration, and perforation of discus. Infections can be bacterial, parasitic, fungal. Functional failures are overdrainage, split ventricle syndrome, pseudocyst, ascites, and metastasis. Acute complications during insertion of proximal catheter. The less occur in shunt insertion, mostly intraparenchymal hemorrhage, more common if old ventricular catheter is removed. So caution must be taken to remove old ventricular catheter. It is firmly adherent to the brain parenchyma. So if not removed easily, please leave it in situ. Neurological injury may occur, usually transient. Hemiparesis is possible if the catheter traverses the internal capsule. Abdominal visceral injury like perforation of intestine can occur after placement of a peritoneal shunt. This is uncommon complication. This is the most common BP shunt complications is shunt malfunction. Failure rate in the first 6 months of life to be higher than that for children older than 6 months. Patient with shunt malfunction presented with symptoms and signs of increased ICP like vomiting, headache, irritability, sleepiness, increased head circumference, bulged or tense anterofrontally, sixth nerve palsy, and papilledema. Shunt block or obstruction, 3 types. This is proximal blockage, bulb obstruction, and distal obstruction. Proximal obstruction is common. Cause is catheter adhering to the wall or embedded in the correct plexus. So during shunt insertion, accuracy is important. In our small study, we found in our hospital, accuracy rate is only 39%. Accuracy can be increased with aid of perioperative ultrasonography or navigation guided shunt insertion. Bulb obstruction is less common due to cellular debris or blood gets into the ventricular catheter, passes into the bulb or obstructs the bulb. Distal obstruction, occlusion by momentum or trapping of debris. In shunt obstruction, shunt patency assessment, we can do shuntogram. In literature, different articles, shunt malfunction rate varies. In our study, BP shunt malfunction was 3.17%. How can we manage the shunt obstruction? If upper end is blocked, treatment is revision of upper end, reposition of the ventricular catheter. If lower end is blocked, treatment is re-explore the abdominal site, check any occlusion, reinsertion in ipsilateral site or contralateral site. When child come with BP shunt malfunction, we try to assess OFC, palpate anterofrontonally, and see the bulb functioning or not by pressing fingers over the bulb. If bulb is collapsed and withdrawn after withdrawal of pressure, it refills. That means it seems to be functional shunt. If after withdrawal of pressure, it remains collapsed, that means upper end is blocked. And when it feels tight, it seems to be lower end block. After revision of the shunt, when revision does not work or patient complained of raised ICP, treatment is insertion of new shunt or endoscopic third ventriculostomy. Again, most common complications of the BP shunt is shunt infection. The majority of the shunt infections occur within the first few weeks to several months after BP shunt placement. Although late shunt infections are observed as well, the most common isolated organisms are Staphylococcus epidermidis, Staph aureus, Streptococci, E. coli, and Pseudomonas. Highest risk for shunt infections are premature neonates in whom the immune system is not fully developed. Shunt infection causes significant morbidity and mortality in children. Prevention of BP shunt infection is essential. After BP shunt surgery, we face varieties of complications. So, to prevent BP shunt infection, we follow a standard protocol to prevent BP shunt infection. Number one, we ensure limited personnel in operation theater, proper prophylactic antibiotic is given, proper painting the surgical site with povidone iodine and wait for 3 minutes, proper hand wash at least 3 minutes, wearing double gloves, Iovan grape is used, and injection gentamicin into the bulb and shunt catheter. Despite this measure, repeat infection is common. Patient with shunt infection presented with fever, infected wounds, infected shunt tract, parietal abscess, pus discharge from wound, cleft skin, brain abscess, subdural empyema. Picture shows redness over the shunt tract. This shunt tract often contains pus. This picture shows abdominal parietal abscess at the abdominal wound. We published our article. In our article, BB infection was 3.17%. In several articles, infection rate is more. According to Infectious Disease Society of America guideline, optimum management of BB infection is removal of the shunt, placement of EBD, intravenous antibiotics, then placement of a new shunt. Shunt placement is performed after sterile CSF culture is obtained. Relapse may occur, reinfection may occur. Relapse is defined infection with same pathogens within 3 months of antibiotics being stopped. Reinfection is defined infection with same or different pathogens after 3 months of antibiotics being stopped. Patients with shunt infection are more prone to subsequent infections than others. Infectious Disease Society of America guidelines recommend a total course of antibiotics of 10 to 14 days, 21 days per gram-negative pathogens. IDSA guidelines recommend that new shunt placed on day 3 after CSF is sterile for coagulase-negative staphylococci infection. On day 7 for QT bacterium, formerly named Propionibacterium acnes, and on day 10 for other pathogens. Rifampicin is used to decrease recurrence in staphylococcal infection. In some studies reported, intraventricular antibiotics and antibiotic impregnated shunts decrease the recurrence rate. In other studies reported, intraventricular antibiotics and antibiotic impregnated shunts did not decrease the recurrence. Another complication of BP shunt fracture or break. It is a rare complication. Shunt tract calcified then cracked, most commonly occurs in the neck, detected on X-ray. Shunt series means series of X-ray such skull, neck, chest, and abdomen to detect the shunt break. For a while, CSF will pass through the fibrous sheath. This picture shows shunt break below the bulb. Below, there is no shunt is seen. After exploration, shunt break below the bulb. Shunt is functioning. Shunt break below the bulb and peritoneal catheter is totally migrated into the peritoneal cavity. In the chest, no shunt tract is seen. After exploration, fibrous sheath around the shunt. At abdominal site, this is fibrous tract, contains no shunt. This picture showed disconnection above the bulb. In the neck, no shunt is seen. X-ray shows this is cranial end. Bulb is displaced downward. In between, no shunt is seen. This is disconnected. This is cranial end. No shunt in between. Bulb with peritoneal catheter is displaced downwards. This is another rare complication, transanal migration. Exact mechanism is not clear. Adherence of the catheter tip to the visceral wall, constant pressure of the catheter tip along with local inflammatory reaction lead to perforation of the wall of the viscera. Entrance of the tip in the lumen and peristaltic activity of the bowel carries it all the way to anus and external surface. Poor general condition of the patient with weakening of the bowel wall, firm end of the peritoneal catheter thought to be responsible for transanal migration. Infants with myelomeningocele having thin bowel wall in home, innervation of the bowel wall may be insufficient. Management of transanal migration. At first, we remove the shunt, and shunt tip is sent for microbiological study, and we give prophylactic or empirical antibiotic therapy such as ceftriaxone, vancomycin, and metronidazole. When sign of raised ICP is present, we give acetozolamide and put EBD. Subsequent reinsertion of shunt in the presence of active hydrocephalus may be done between 6 and 12 weeks. Regarding removal of the shunt, we open the abdominal previous scar and cut the shunt, and peritoneal end of the shunt is pulled out through the anus, and another incision over the cranial side, and upper end of the shunt is removed. It is another complication of BP shunt, intracranial migration. These are many factors that are proposed responsible for the migration of the shunt. Excessive neck movement producing windlass effect with large subgaleal space creating for bulb and dilated ventricles with negative functioning pressure with positive intra-abdominal pressure thought to be responsible for intracranial migration. The memory of the device placed in the packaging allows shunt tube to recoil, explained as memory phenomenon. Other factors are younger age, thin cortical mantle, malnutrition, large bar hole, wide dural opening, shunt catheter not anchoring to the pericardium, cylindrical bulb, especially in Chebra shunt, and straight course of shunt tunnel, also responsible for intracranial migration. To prevent intracranial migration, smaller dural opening, smaller bar hole, or anchoring to the pericardium is ensured. This is rare complication of BP shunt. It is intrathoracic migration. This child presented with severe respiratory distress and admitted in ICU. Chest X-ray showed intrathoracic migration of the lower end of the BP shunt, probably through diaphragm. Unfortunately, child died in ICU. Migration into the scrotum presented with scrotal swelling, unobliterated processes vaginalis in pediatric patients lead to BP shunt distal catheter migration into the scrotum. This X-ray shows the scrotal migration of the BP shunt. Treatment is explosion of the inguinal region, reposition of the shunt, repair of processus vaginalis. Another common complication of BP shunt is over-drainage or over-shunting. Either may be seen as extracerebral fluid or blood collection, or may be classified as split ventricular syndrome. Subdural fluid collection due to collapse of the ventricles, subdural fluid collection can accumulate. Programmable valve can decrease or stopping over drainage. Treatment is subduroperitoneal shunt, of course, low pressure. In subdural hematoma, with collapse of the ventricles, blood can accumulate due to rupture of the breathing vein. Treatment is evacuation of hematoma by barhole aspiration. CT scan showed bilateral subdural hygroma, cause is overdrainage of the shunt. Sudden decrease in ICP allows brain to fall away from the skull, opening up the subdural space. Vessels traversing the subdural space get stressed, resulting in transudation of fluid from the intravascular compartment to the subdural space. Treatment is barhole aspiration, but the result is unsatisfactory. Reaccumulation of fluid is common. So alternative option is low pressure subduroperitoneal shunt. Programmable shunt can decrease overdrainage and ultimately subdural effusion. Subdural effusion coexisting with hydrocephalus secondary to CSF shunt under drainage. Extracerebral fluid collection is secondary to pressure-related CSF. It spills from the ventricles into the subdural space. Impaired physiological CSF drainage along Barker-Robin perivascular space in raised ICP. This CT scan showed subdural effusion with ventriculomegaly. Treatment is revision of BP shunt. Subdural hematoma, overdrainage of shunt, sudden decrease in ICP allows the brain fall away from the skull, rupture of the breathing vein causes subdural hematoma. This scan showed subdural hematoma. Treatment is barhole and evacuation of the hematoma. Programmable shunt can decrease overdrainage and subdural hematoma. This is a picture of unfortunate girl, had hydrocephalus. We put a shunt and in postoperative period developed subdural hematoma. We did barhole and aspiration of the hematoma, but subsequently subdural hematoma developed. We did craniotomy and removal of the infective materials, but again developed subdural empyema. Slit ventricular syndrome, overdrain of CSF because of siphoning effect, small ventricle cause intermittent ventricular catheter obstruction, poor compensatory mechanism, poor brain compliance causes headache, nausea, vomiting, signs of raised ICP, ultimately coma. This is split ventricular syndrome due to overdrainage of the CSF. Due to overdrainage, shrunken skull. Big child with big head, we underwent BP shunt, and in postoperative period, shrunken skull developed. Loculation sequelae of ventriculitis, shunt will drain only a portion of ventricular system, leaving another one enlarged and causing mass effect. Image showed isolated lateral ventricle or isolated fourth ventricle. CT scan showed septated or loculated hydrocephalus. This is another CT scan showed septated or loculated hydrocephalus. Treatment is difficult. We do endoscopic septation or communication between loculation, and subsequently we put VP shunt. In debilitated patients with thin skull causes skin erosion over the shunt catheter. Skin is slapped out over the shunt catheter, shunt is exposed. Treatment is just secondary suture and improve the nutritional status of the child. This is another picture showed shunt extrusion through the skin in right lumbar region. Peritonitis is a rare complication. BP shunt is common association, infection, common association, conservative management with antibiotics. If fails, requires laparotomy. Intestinal obstruction is a rare complication of BP shunt surgery. Cause is adhesion or shunt knotting. Conservative management may improve this condition. If fails, require laparotomy. Picture shows lower end coiling. This picture shows peritoneal catheter coiled. This coiling does not always cause intestinal obstruction. This is complication of BP shunt, peritoneal cavity unable to absorb frozen abdomen causes CSF ascites. Abdominal paracentesis may help the patient symptomatically, but recurrence is common. Alternative option is ventriculoatrial shunt. Pseudocyst or loculate pockets filled with unabsorbed CSF. Abdominal pseudocyst is a rare complication after BP shunt and could result in shunt malfunction or abdominal symptoms and signs. CT scan showed abdominal pseudocyst and peritoneal catheter confirmed by ultrasonography and CT scan of the abdomen. Treatment is open exploration, cyst fluid drain, partial or complete excision of the cyst wall, and reposition of the shunt. CSF leak may occur, common at cranial site. To prevent CSF leak, a smaller dural opening can help during insertion of the ventricular catheter. Picture showed large pseudomeningocele at cranial site due to CSF leak at cranial site. A smaller dural opening during insertion of the ventricular catheter prevent the CSF leak and subsequently pseudomeningocele. Seizure may occur, may associated with malformation of the cerebral cortex. We usually prophylactically give anticonvulsant during BP shunt surgery and in post-operative period. After BP shunt surgery, a child may have cognitive delay or motor disability. In our study, few child had walking difficulty, developmental delay. In our small study, only 41.27% had good outcome with normal development and normal IQ. In conclusions, insertion of ventriculoperitoneal shunt is routinely done by all neurosurgeons. Great care and precautions should be taken during insertion of the shunt system, starting from scrubbing to avoid complications such as infection. The advent of endoscopic third ventriculostomy has gained popularity due to the high complication and failure rates of ventriculoperitoneal shunt. Despite complications, ventriculoperitoneal shunt remains the main surgical procedure used for hydrocephalus management. This is end of my talk. I am stopping here. Thank you very much, everyone.
Okay, very good, Doc.